morning or good afternoon,
Wherever we're located,
wherever
right?
we are.
Great. Good morning, Dr. Wang. How are you?
I'm good. I'm
Uh,
good.
Good. Okay, so we just went live and we have a few people starting to join. So hello there, everybody. First of all, I am so glad that people could join us, and of course, Dr. Wang could join us for this special live stream Q&A for in advance of Global Porphyria Day, which is taking place tomorrow. And my name is Kristen Whedon. I serve as president of the United Porphyrias Association. I am also a caregiver and mom of a child with porphyria, with erythropoietic protoporphyria. And while Dr. Wang, if we're getting him set up, I just wanted to tell you just for a moment about this year's Global Porphyria Day theme. And this will lead, I'm sure, Dr. Wang, in some of the questions we have this morning or this afternoon. And the theme this year is real for UPA is real people, real pain. And that being because the major part of a porphyria experience is the pain that impacts the daily life during a reaction or during an attack. And with this awareness campaign, we wanted to hear individual voices and descriptions of pain. So you, as viewers, can participate by creating your own real pain, real people, real pain challenge, and describe a video. And my tech team behind the scenes, Anna and Myra and Katri, will put some information in the chat for you to be able to do that. So, but without further without further time, I would like to introduce Dr. Bruce Wang. Dr. Wang is our brilliant Porphyria expert from University of California, San Francisco. As you can see, he's given up his portion of his Saturday morning with his family to join us, and most importantly, to answer your Porphyria questions. So we are going to dive in. First, Dr. Wang, hello, welcome.
Hi, Kristen. Hi, everyone. Happy to be here. Happy to chat with everyone today and answer any questions that you guys may have about the Porphyrias.
Terrific. Thank you. And so here's how this is going to go. We are going to have folks put the questions into the chat, and I am going to read the questions out loud to you, Dr. Wang, and we're going to see if we can stump you. How's that sound?
Sounds good.
Is there anything before we go into any of the questions? Is there anything you wanted to share about pain in the porphyrias, or anything about porphyria in general, or the work you're doing right now to get us to launch us?
Sure. Maybe I'll do a quick introduction for about myself. So I'm a hepatologist. As Kristen said, I work at University of California, San Francisco. I run a basic research lab studying liver biology and also heme biology in the liver. And I also run the Porphyria clinic at UCSF and have been part of the Porphyrias Consortium for the last, I guess, 16 years now.
Wow.
As far as that's you know, I can't believe our consortium has been around for that long.
Yeah.
And I'm also a scientific advisor for the UPA. And so, yeah, so on the topic of pain, and pain is obviously a major part of the porphyrias. It's not just the acute porphyrias, but EPP also. Significant part of the experience for the majority, I would say, of our porphyria patients. And I would say it's an area that we have very poor understanding about. You know, we think that for the acute porphyrias, it's the nerves that are damaged, but exactly how, we really don't understand the pathophysiology beneath, underneath it. And for EPP, especially, we really don't, we have a hard time, actually, we don't really understand at what level of the tissue that the protoporphyrins are being activated in. You know, we think it's more deeper in the skin than some of the other porphyrias, but how that elicits pain, we don't know. And that's why actually participation by patients is so important in this, is that we need more research on this, both on the basic science side, but then also on the clinical side, and that will require patient participation.
Well, you just did a plug for research, so we got to tell a little bit about how do you get involved in research, and then we'll go to all the questions that are
Yes.
coming in hot.
Yes. So I mentioned about the Porphyrias Consortium. There are also other consortiums around the world. So for folks who are joining in today from Europe, for example, there's a European Porphyria network, and they have a large cohort of patients as well. But in the United States, we have had a longitudinal study for all of the Porphyrias going on for the last 15 years, 16 years now, going on year 16. And all patients with confirmed diagnosis of porphyria are eligible to participate in this study. And it is what we would call a natural history study. Basically, this group of diseases is so rare that there are a lot of fundamental questions that we don't understand about it. And the only way for us to get more answers is to be able to follow patients and get information, clinical information from patients, including their experience, for example, with pain over time, not just during acute episodes, but also chronically. In between episodes, over a long time, even after the episodes have stopped. And so that was the goal of this study, is to follow patients over a long time, essentially the lifetime of our patients, so that we can learn more about how these diseases progress and what are the complications. And then as we have more therapies, because this, I would say the last 10 years has been a very exciting time for clinical therapies for the porphyrias. How well do the therapies really work? And what's the best way for us to treat patients now that we have more options available? So if you're interested in getting involved in research, you can reach out to Kristen and her team at UPA. You can reach out to myself at UCSF, and I'm sure, Kristen, you can send them information about the other sites of the Porphyrias Consortium, and patients can get connected to their local Porphyria experts.
Great. Thank you, Dr. Wang. Research is absolutely critical to move the needle at any of this. So I appreciate opening the discussion with that. Okay, we are going to launch into the questions we have. And the first question that I see is about, it's acute porphyria, someone with AIP. And it says, I am on Givlari, but have had chronic pain, nausea, and autonomic issues. What daily drugs are best for this? Let's see, there's one more comment. SNRI and TCA are good for the pain, but have hard side effects such as weakness and brain fog. Lyrica and cannabis were not good for me. Can you please speak to that?
Yes, excellent question. Maybe before I answer that question, I'll just, for some of the other folks on the line who maybe are not quite as familiar with what we're talking about here, which are chronic symptoms in patients who have acute porphyria. Patients who are on Givlari are patients who are having frequent recurrent attacks, because that's the indication generally for this medication. So in the acute porphyrias, I think most patients are familiar with the significant neurologic symptoms, especially pain during an acute attack. But every attack of every acute porphyria attack is an episode of nerve damage. And over time, the nerves in patients who have either many recurrent attacks, repeated attacks that have accumulated over their lifetime, or in some patients with really prolonged severe attacks that are untreated, you can have more permanent neurologic damage. And we think that is the reason for patients to have more chronic symptoms over time with acute porphyrias, when they're no longer, let's say, experiencing their typical episodic features of the acute attacks. And we also see this biochemically when we look in the urine for the chemicals that we think are causing the initial neurologic attacks, high levels of ALA and PVG. In some patients, again, over time, those levels go down to normal, but the patients can still have chronic symptoms. So in this case, I will say that it is difficult to treat this type of chronic neuropathic pain. What we are good at for the treatment of the acute porphyrias is stopping an acute porphyria attack. We have good treatments at lowering levels of ALA and PVG so that we stop or prevent this neurological damage from occurring. what we're not very good at, we don't have good medications, specifically in the porphyrias, for helping nerves heal, especially nerves that have been damaged and may potentially be permanently damaged. And patients can oftentimes experience very similar symptoms, unfortunately, as during their acute episodes, when it's these same nerves that have been damaged before. If they're permanently damaged, they may give patients the similar symptoms. And then zooming back outside of the porphyrias in pain medicine, pain management, and then also in this case, we're talking more neurological pain management for neuropathies. The patient mentioned a number of different treatments that are available for neuropathy. I would say by and large, they're not that great, in terms of effects, and you sort of just have to try different ones. We do not have a whole lot of clinical data to show if one of these neuropathic medications is better than the other for treatment of this type of chronic neurological pain in acute porphyria symptoms.
Okay, great. Thank you for that response, Dr. Wang. I am going to stick with another, acute question, a very specific one for AIP. I had an attack in February after contracting COVID. For the first time, I have had muscle and nerve issues. I've had small, constant muscle twitches in my hand and chin for the past 2 months. Is that something that can happen from an attack? And what can be done, if anything, to help for this? And this patient is coming in from Germany.
Okay, all right. So, this is a nice segue from our last question. So, after an acute attack, so you have this episode of nerve damage, it will take weeks and sometimes months for the nerves to fully recover. So it is certainly possible that the ongoing symptoms that you are experiencing are residual nerve damage from the last attack. The other thing that I think we should look into is whether or not you are still having ongoing high levels of ALA and PPG that may be causing persistent neurological damage. So in this case, I think, what is really important here, and this is a general comment in the acute porphyrias, which is getting regular data about your levels of ALA and PBG, and we can do this in urine, and this is a random urine test. You do not need to do a 24-hour urine because the levels are so high in the body that information is really helpful. So in this case, I'd want to know what your baseline ALA and PBG levels are, if that is available, what the levels were during this attack that you had in February, and what are the levels are now, because the ongoing symptoms may be because the levels of ALA and PBG are continuing to be elevated, and so lowering them more might help resolve the symptoms here. The other possibility is that if the ALA and PBG are now normal, or back to your own personal baseline when you're more asymptomatic, then I think there are still two possibilities here. One is that we may just need to give your body more time for the nerves to fully heal. Okay, and then the second thing is that there are some reports after COVID of rare, incidences of neuropathy and neurologic damage after COVID. And so in this case, you'd want to be able to differentiate between those two possibilities. And again, here, I think some biochemical data about what the ALA and PBG levels are will be helpful here.
Okay. I want to ask on that, and this is just an aside, I want to ask that you talk about tracking symptoms based on labs and biochemical labs, right? But then if someone doesn't have that available to them very easily, does tracking symptoms in like a digital tracker or journaling, is that also helpful for this for patients?
I think yes. I think having a symptom diary can be helpful here in patients who don't have access to ALA and PBG. But I think because the symptoms, even though for acute porphyria, for each particular patient, I think most of the folks who have acute porphyrias on this call maybe, probably have experienced this, your symptoms tend to be very similar from one episode to the other. So you tend to know if your symptoms are due to your acute porphyria or not. But because the symptoms are so broad, sometimes we can't tell if what you're experiencing is from an acute porphyria attack? Is it from the residual symptoms from an acute porphyria attack?
Right.
Or can this be from something
Right.
else? Because there certainly can be other things. We just talked about post-COVID syndrome as potentially, one etiology that may have some symptom overlap.
Okay.
And I think part of the difficulty here is that with acute porphyria attacks, all nerves in the body can be damaged. And so the kinds of symptoms that you experience can look like or can overlap with many other health conditions. And so for the acute porphyrias, what really helps differentiate acute attacks, which again, I'm really emphasizing the acute attacks because that's what our two current treatment modalities target. So we have panhematin, which is used during an acute attack to stop the acute attack. It works by lowering ALA and PBG. And we have gavosiran, which primary indication is to prevent acute attacks from occurring. And again, it works primarily by lowering ALA and PBG. So knowing what the ALA and PBG levels are really important. And for those patients who don't have good access to ALA and PBG urine testing, that also is something that we can try to help with, both within the Porphyrias Consortium, and I'm sure Kristen, you at the UPA can also help direct patients to resources.
Yeah, absolutely. Absolutely. On that point, especially on panhematin, I have a question again from Germany that this patient has received heme 3 times. The heme seems different. I do not get sick from it, and it doesn't have to be hidden from light or protected from light. Can you speak to the difference between panhematin and Normasang?
Yes. So there are 2 formulations of heme treatment in the United States. The brand name is panhematin. In Europe, it's Normasang or heme arginate. They're both for purified heme. The carrier molecules are slightly different. The other main difference is that Normasang or heme arginate has human albumin already added to heme, which helps, we think, reduce the risk of thrombophlebitis or the chemical burn injury that can happen if heme is infused through small veins. In the United States, our general practice has been that we infuse panhematin with adding albumin to it. So essentially, you are getting the same thing as you would get with Normasang. But the 2 formulations are slightly different. The active ingredient heme is exactly the same. The dosage is also the same. The main difference is whether or not albumin is added. And in the US, we generally mix the panhematin with albumin so that it should be quite similar.
Okay, terrific. Thank you for that clarification. I'm going to pivot over to an EPP question, and this is a direct question about pain, Dr. Wang. Is there anything that can help with pain? And I think anticipating the answer is going to be no. Why not?
Right. So many things have been tried for pain relief, especially in a more severe after really prolonged light exposure for patients with EPP. The typical pain medications really don't work. Certainly over-the-counter stuff does not work. Ibuprofen, Tylenol doesn't really work. Even opiates, which are, which require very high doses for our acute porphyria patients with that type of neuropathic pain, but is effective if given in high enough doses, seems to really not do much for EPP. Things like running, putting your hand on ice cold water, running it in a running water. There are some things that may give you temporary slight relief, but really we don't have anything that's very effective in addressing the pain in EPP. Antihistamine medications, things like Benadryl, basically things can kind of knock you out and allow you to hopefully sleep for a little bit, but it doesn't really address the pain. And the reason is related to the fact that we don't really understand where specifically in the skin does activated protoporphyrin. So in EPP, the chemical that abnormally accumulates is protoporphyrin. And this is a chemical that is quite different than the other porphyrins that are elevated in other skin porphyria. So patients with PCT, with CEP, or variegate porphyria and hereditary coproporphyria, who have also photosensitivity, they tend to have porphyrins that accumulate, and these are more water-soluble porphyrins,
Right.
and they can go directly into our skin layer, and that's why across all of those 4 conditions that I talked about, they all tend to get blistering skin lesions. In EPP, protoporphyrin is a very water-insoluble chemical, and so it tends to stay only within red blood cells, and then if it's released, it'll stay generally within the blood vessels or the small capillaries that carries blood underneath our skin. So the location of where protoporphyrin is a little bit deeper in the skin, and we don't actually know then the steps that occur after protoporphyrins underneath the skin in the blood vessels get exposed to sunlight, and how that leads subsequently to pain. It probably is a type of, perhaps neurological pain, but it clearly is quite different than in the acute porphyrias, because some of the same pain medications for the acute porphyrias have very little effect in EPP. So it's a very long way of saying we don't really understand why patients with EPP have the kind of pain that they do, and we need to do more work on this area.
Yeah. Do you know if any work is being done by any of our researchers and colleagues in this area, or if there's any anticipating any work in this area?
Yes, so there is some work happening in this area. So, for example, Herb Bonkowski and his group in Wake Forest have been looking at this, at the how protoporphyrin activation may lead to the cells that line blood vessels, how that affects them. Makiko Yasuda, who's a porphyria basic science researcher at Mount Sinai, is also working in this area in some collaborations with Dr. Bonkowski. So there is active work going on for this, but I think more is needed.
Of course. Yeah, that makes me really happy to hear, though. Okay, we're going to go on to another cutaneous question. This is from a caregiver of EPP. The question is, my 9-year-old has EPP. Last weekend, she had a bad reaction on her face with a UV of 2, which she hadn't had before between 8 and 10:30 a.m. I think I've read before that EPP reactions can become more severe during puberty. Is this true?
Have not actually seen good data to show that. So protoporphyrin, its production is primarily in red blood cells in the bone marrow, and during puberty, obviously our sex hormone, the levels change throughout the body. That has a really significant effect on the liver, and so what is very clear in terms of change in puberty are more for patients with the acute porphyrias, because in the acute porphyrias, where ALA and PBG are produced, is in the liver. And so during puberty, with changes in systemic hormone levels, we clearly see an increase. In fact, prior to puberty, acute attacks are quite rare for in the acute porphyrias, probably because the systemic hormone levels are quite low. Okay, now for EPP, during puberty, systemic hormone levels don't quite affect hemoglobin production so much in red blood cells. So I've not really seen any data to show that protoporphyrin levels change or increase significantly during adolescence, especially during puberty. Now, there may be other so separate from that, during puberty with just more growth, people going through a growth spurt, the body may need to make more heme and red blood cells to accommodate that. So you might see slightly higher rates of protoporphyrin levels, for example, in kids during a growth spurt. That, to be honest, we have not looked at very much, and I'm not aware of anything in the literature that looks at that. But I could see that as a potential connection, but I don't see a connection between changing levels of systemic hormones and protoporphyrin levels. So I guess this will be a plug for me to say that for patients with EPP, we should be measuring their protoporphyrin levels on a regular basis. How regular? I would say for EPP, probably once a year is a good idea to know what the baseline levels are. And in terms of testing for protoporphyrin, so unlike the test what I just mentioned earlier, ALA and PBG, which is in urine, protoporphyrin, you have to look for it in red blood cells. So it's a specific test that you have to order for erythrocyte or red blood cell protoporphyrin levels.
Okay. While I'm looking at the next question, would you please clarify in EPP especially UV versus visible light? Thinking about what impacts EPPers and
Right,
XLPers.
right. So for EPP, and this is true actually for porphyrins in general, because of the chemical structure of porphyrins, the wavelengths of light that have the most activation of porphyrins are actually in the visible spectrum of light and not in the ultraviolet range of light. This is one of the reasons why typical sunscreens, which are really meant to protect against UV light induced skin damage that leads to skin cancer, they have very little effect and protection for our patients with cutaneous porphyrias. This applies for EPP also, but as well as for PCT and CEP, also the hereditary coproporphyria and variegate porphyria patients. And that really the only thing that really helps here is more barrier protection. So the kinds of sunscreen that are metal based, essentially the ones that leave a white, covering on your skin, those are the ones that may have some effect because they provide a protective layer. It would be better if you could wear long sleeve clothing, pants, wide brim hats as further either avoidance or a better barrier for sunlight.
Great, thank you. All right, I'm going to move over to a question in PCT. I've been diagnosed with PCT, but have lots of pains, as I also have heard other PCT sufferers do, and PCT is Porphyria cutanea tarda. However, pain is usually not listed as a side effect of PCT. So is the pain likely a different underdiagnosed problem, or could it be caused by the PCT? Could it be something else, or is it the PCT?
Right. So PCT, a little bit different than the other porphyrias, is that PCT, by and large, patients who have PCT do not have an underlying genetic mutation in the heme biosynthesis pathway. So the acute porphyrias, EPP, CEP, VP, and HCP, all of those are caused by genetic mutations that lead to a partial defect in one of the heme biosynthesis enzymes in the body. Patients with PCT actually most of the patients, 80% or so, don't have underlying genetic mutations. And what they have instead is some other problem typically happening in the liver, some other underlying liver disease that inhibits this specific enzyme called UroD within liver cells. And that leads to high accumulation of the porphyrins that ends up leading to the skin symptoms, the photosensitivity, the blisters that happens in PCT. So there can be pain in PCT. Generally, that happens after the blisters the skin that covers the blister has been unroofed and you have now exposed skin, and that certainly can be painful, okay? Now, where I think it'll be important in this case with this particular question, to also look into what the underlying, potentially liver disease that is causing the PCT. That's important because some liver diseases can cause other kinds of pain. So, for example, a common cause of Porphyria cutanea tarda is iron overload. There's another genetic condition called hereditary hemochromatosis. This is an inherited cause of too much iron in the body. And if you have too much iron in the body, first the liver gets injured, but at some point you can have iron deposits in joints and patients can have joint pain from that. So just as one example, patients with other kinds of chronic viral hepatitis, hepatitis C has been commonly associated or has been causative for PCT. Right. Chronic viral hepatitis can also cause joint pain, as so with some of the autoantibodies that are produced from there. So in this case, I think we'd want to look a little bit more carefully into where is the pain? Is it, if it's right where your unroofed skin lesions are, these blisters are, that makes sense. That's probably directly related to PCT. And again, PCT can be treated quite well and quite effectively with therapeutic phlebotomies, hydroxychloroquine, or if you have an underlying liver disease, treating the underlying liver disease will make PCT go away. So patients with chronic hepatitis C, when the hepatitis C is cured, the PCT goes away and it doesn't need to be treated. Right? So those are the ways of trying to figure out, hey, is this pain from my PCT or is it from something else?
Okay, terrific. Well, thank you for a terrific answer. Okay, I'm flipping back to an acute porphyria question. And this is from a patient who says, my hepatologist says no to all NSAID pills, but I have coming and going radiating pains around the spine that NSAIDs used to help with a lot. Possible inflammations from weak muscles while doing physio. Do you have any solutions or suggestions about this? Small doses. This patient also has a genetic polycystic liver.
Got it. So, the class, the NSAID class of medications, very commonly used and effective anti-inflammatory medications, can be quite good for joint pain and also nerve pain from nerve impingements in the spine. The important thing to know is that NSAIDs are not actually primarily metabolized by the liver. Okay. What I worry more about in NSAIDs is actually kidney damage. It is excreted by the kidneys, and folks who are taking NSAIDs for a long period of time with high doses are at much higher risk of kidney damage than liver damage. So, as regards to the acute porphyrias, we do want to be careful about medications that are metabolized or broken down by the liver, because that breakdown process may require the liver to make more heme, and that can cause the liver to accumulate more ALA and PBG, and that might induce an acute porphyria attack. Okay. So patients with the acute porphyrias really do have to be careful about medications, okay? And just as an aside, patients with the cutaneous porphyrias generally do not. Okay, because medications are not metabolized by red blood cells. So, for example, patients with EPP, you're not going to get a medication-induced worsening of your EPP because mostly the medications are broken down by the liver and not in the bone marrow. Okay, now, but the NSAIDs as a class of medications don't induce heme production in the liver. So, from an acute porphyria perspective, they are safe. Okay, and I will go even further and say that from a liver perspective, I see patients with chronic liver disease, including patients with cirrhosis. The NSAIDs are fine to take in patients even with, abnormal liver function. So I don't see a reason why NSAIDs would be contraindicated in this patient. Now, some patients with polycystic liver problems may also have cysts in the kidneys. And so if you're a patient who has chronic kidney problems and your kidney function is abnormal, that would be a reason to really avoid the NSAIDs.
Okay. Thank you. I have another question regarding drug safety for acute porphyria. There's some comment specifically about particular drugs, and this patient is fighting rectal cancer and has AIP. But the exact question is, how do I report attacks related or triggered by a specific drug so other patients know how to proceed with caution? Can you speak to the drug safety?
Yes. That is a great question. And also a great opportunity for me to plug in an ongoing research study that actually is being hosted out of UCSF that I direct, specifically actually about this specific question, which is how do we figure out if an attack is due to a medication. So in this case, we have an ongoing web-based study where, and Kristen, perhaps the UPA can send us some links to this drug safety study to the folks on this call, where patients can report both safe and unsafe medication use as it relates to the acute porphyrias. So we have a questionnaire where we will ask you to put in information about the specific drug, the dose, the duration that it has been used, and then information surrounding the attack. So let me zoom back out for a second. So we've been talking about drug safety in the acute porphyrias, and over the past probably 30 to 40 years, there's been a lot of accumulation of information about drug safety, and we've had several drug safety databases that have been created. In fact, in the U.S., we helped maintain one until pretty recently, very actively. over time, these lists have become quite bloated, and the evidence supporting or behind these recommendations about whether a drug is safe, likely unsafe, or unsafe, that's been the typical kind of classification of the drugs.
Mm-hmm.
The data behind it is not very good. And so there's been a need to get more of this data. And the folks in Europe are also working on this. The patients may know that probably I would say the most up-to-date drug database currently in the world is hosted by the Norwegians in Norway. It's called NAPOS, and they recently actually just updated their website, and we should have now a more stable. For a while, that website was a little bit unstable, but they've updated it, and now we have kind of the most up-to-date information. But even that database, the evidence supporting some of the unsafe drug list on there is not very strong. And so we need more information. And so really want to thank this patient for bringing this issue up. And that's what this web-based questionnaire that we are conducting, this study that we're conducting, is really trying to address. This study has been going on for a couple of years, and it will be kept going indefinitely going forward, because we just need to capture more and more of this information.
On behalf of the patient community, we just really appreciate your work there, because this is needed to be done. So thank you. I am going to add another acute question. I'm going to flip back to cutaneous porphyrias, but I think this is important. Well, all of them are important, but an acute patient question: should I seek hospitalization each acute attack? I've had so much medical trauma that I tend to just let time pass by at home instead. However, neuropathy and muscle spasms have been getting worse.
Yeah. So I think this ties back to the first couple of questions that we had, which are about the chronic symptoms, and basically we don't have great treatment for the chronic symptoms, but we do have good treatment for stopping or preventing acute porphyria attacks. So the way to prevent this chronic symptoms from happening is, number one, we need to diagnose the condition earlier, right? But then number two, as it relates to this question, is we should treat the attacks aggressively and early, okay? So I have been, so for all of my acute porphyria patients, I've been telling them to let me know as soon as they start developing symptoms, right? So most of you who have acute porphyrias probably, know that the symptoms come on generally over the course of a couple of days. You know when you're about to have an attack, and there are things that you can try at home, but I've been telling my patients to let me know within the first 24 hours. And if it lasts longer than 24 hours, we should get you treated with panhematin, okay? In an ideal setting, if you can have access to this, then you go to an outpatient infusion center and get panhematin done as an outpatient, so that you don't have to go to a hospital and be hospitalized for it. Unfortunately, that kind of setup may not be accessible for all patients. And so for those other patients who don't have access to an outpatient infusion center, then my recommendation is still to go to your local emergency room or local hospital to be, if it requires a hospitalization of the panhematin, I think it is worth it. Now, a lot of patients have had a lot of, unfortunately, difficult encounters with healthcare care providers who are not accustomed to seeing patients with acute porphyria, which is pretty much everywhere, because this is unfortunately a rare enough symptomatic disease that most healthcare providers and ED physicians are not aware of them. So my recommendation is, as much as possible, if you can, establish a relationship with a local hospital, with a local ED, so that they know your symptoms, they are aware of what you go through, so that you can get treatment quickly. And reach out to one of us, any one of our, Porphyria experts. Most of my patients are spread out all across the west coast of the U.S. So I'm very accustomed to talking to local ED physicians, local community hospitals, and healthcare providers are very amenable to help set this up if they, once they talk to another provider who has experience with this. Yeah, but I would not try to ride this out at home, because what you run the risk of is development of more permanent damage, and then in the long run, having chronic symptoms that are much more difficult, I think, to treat.
I'm going to guess don't have very many patients on here who have a doctor or their specialist that says, let me know when you're starting an attack. So that is just amazing that you do that, Dr. Wang. I am going to ask a question about HCP, which I need to be able to see on the screen here. Okay, the HCP, this is a caregiver who says, I would love to learn more about autonomic symptoms. Our daughter with HCP is having autonomic symptoms and is now diagnosed with dysautonomia. Although she has had the genetic testing, her levels are not high enough when testing during the attack. We feel like we are going in circles on this. How would you advise this parent?
Yeah. So patients with HCP, and my answer will apply to patients with VP and AIP as well,
Sure.
who are having high levels of ALA and PBG, or have attacks with high levels of ALA and PBG. The nerve damage that we've been talking about can also affect autonomic nerves, and so a very common set of symptoms during acute attacks are increased heart rate, high blood pressure, and other kinds of autonomic nerve instability, okay, and damage.
Okay.
So over time, that can lead to chronic autonomic issues, okay, if there is essentially ongoing high levels of ALA and PBG. And again, that we can treat, right? We can lower ALA and PBG levels with chronically with gavosiran, or acutely with panhematin, and that should allow the autonomic nerve symptoms to go away, maybe given some time of recovery. Okay, there can be other conditions that cause also autonomic nerve damage as well. So I think in this particular case, in a patient who it sounds like does not have high levels of ALA and PBG, then if that's repeatedly the case, I'd also want to know if there has been ever any episodes where we have shown high levels of ALA and PBG, because another possibility is that your daughter had a prolonged and severe acute attack episode, and what we're dealing with is chronic nerve damage of the autonomic nerve system. Okay. That can happen rarely, but we have seen that, just not that dissimilar to some of the chronic pain issues that we've been talking about for the acute porphyria patients. But if there has not been a history of either frequent recurrent attacks, or a history of really severe prolonged attacks, and currently the levels of ALA and PBG are normal, then I really want to look very carefully at other causes of autonomic nerve issues. Okay.
Great, thank you. Okay, we're going to flip over to EPP and in particular testing for EPP. Before I do that, I want to note that the study that Dr. Wang discussed about drug safety is linked in the chat for you to be able to access. Okay, for EPP, for our blood to be tested properly, it needs to be protected from light. After it's spun, does it still need to be out of the light before boxed with dry ice and shipped to the lab? Can you speak specifically about testing for EPP?
Yes. So actually, I will mention this for most of the porphyrias across the board. It is important that we protect samples from light, but brief amounts of light exposure is really not going to have a significant effect on the test results. Okay. For protoporphyrins specifically, we measure it in red blood cells, so the levels are within red blood cells. In that case, actually, the brief amount of light exposure that may happen during handling of the samples, the blood maybe need to be changed from the tube to a centrifuge, or it can be spun down and then taken out of the centrifuge into another tube. That slight level, that could be 15, 20, 30 minutes of indoor light exposure will not have any effect on the protoporphyrin levels. Yeah.
Okay, terrific. Labs, speaking of labs, but again, flipping over to acute hepatic porphyria, what yearly labs would you recommend, if any, for AIP?
Yeah. So patients with AIP, and again, this answer applies to across all of the acute porphyrias. Couple of long-term complications that patients should be aware of. Number one, kidney damage, especially in patients who are having acute attacks. They are at risk of developing long-term kidney damage, probably because some of the autonomic instability that happens during acute attacks, some of the high blood pressure that occurs. There may be other reasons. There's another associated genetic condition, patients with mutations in this protein called peptide-2 who also have acute porphyria are at much higher risk of developing kidney damage, for example. And so we recommend annually a kidney function test with a serum creatinine. Liver function, so about 15% of the cases of acute attacks will have slight elevations of some liver inflammation, but the risk of chronic liver injury is quite low. So it's not really necessary for us to do annual liver function follow-ups for the acute porphyria patients, okay? But the other complication that patients should know with the acute porphyria is long-term is the increased risk of developing liver cancer. Now, that risk generally is very, very low before the age of 50. In fact, of all the reported cases of HCC or hepatocellular carcinoma, that's the liver cancer that patients with acute porphyrias get, all of the known cases have occurred in patients older than the age of 65. But having said that, our general recommendation is that after you reach the age of 50, you should get regular liver cancer screening. And so that should be with every 6 months, an abdominal ultrasound and a blood test for serum alpha-fetoprotein, which is a liver cancer marker. That is the standard liver cancer screening protocol for patients with chronic liver disease who have cirrhosis or patients with chronic viral hepatitis B. Those are the two other conditions that increase risk of liver cancer. And we treat our acute porphyria patients in a similar way. So once you reach the age of 50, we recommend that you have regular liver cancer screening. So annual testing to monitor kidney function, and then annual, and then at least annual, but better yet, if you can do every 6 months, liver cancer screening. And then I also recommend regular urine test for ALA and PBG. Certainly if you're having symptoms, but if not, probably doesn't have to be once a year if you've been really stable, but once every couple of years, I think would be a good idea.
Okay, so a lot of our patients will have trouble sort of accessing that level of testing. Should they be going to a porphyria specialist, to a hepatologist? Can their hematologist order this, a primary? Where should patients go to say, I need this testing, this is recommended annually?
Right. So a couple of things for patients on the call to know. There have been, we have the Porphyrias Consortium, so a group of porphyria clinicians based in the United States. We have written a couple of clinical guidelines for healthcare providers. This was published over the last couple of years that specifically addresses this question of long-term follow-up, what types of testing should be done. And we've done this for the acute porphyrias, and we've done this for EPP also. So, there are guidelines that are out there for clinicians to be able to follow, and that includes your primary care provider. So the test that I've mentioned, that can certainly be done by a primary care provider. An annual, blood test that includes serum creatinine, that should be done. That can be done by the primary care provider. And testing, ordering for the abdominal ultrasounds and serum alpha-fetoprotein, that can also be done by primary care providers.
Okay. Terrific. Thank you for that. Okay, I'm going to ask a question about carbs and AIP. So let's focus on a little nutrition here. I understand I have to get my carbs with AIP. I would like to know if getting too much protein can be an issue.
Okay. So first, the question of this increased consumption of carbohydrate. Well, what's the relationship between carbohydrates and acute porphyria attacks? Okay. So the connection here is based on actually some animal studies in laboratory mice, which show that with prolonged starvation states, okay, and I really do want to emphasize that this is prolonged starvation states. This isn't, I've gone 4 hours in between a meal. This is, somebody who's going on a crash diet, somebody who hasn't eaten or drank anything with taken in any calories over 48, 72 hours, really prolonged states of starvation that can induce liver cells to make more heme. Okay, that has been shown in laboratory animals. I want to emphasize that that has never been proven in humans, okay, including in acute porphyria patients, that the same mechanism occurs. But we think that it would be reasonable in the early stages of an acute attack. So when you're first starting to feel your symptoms come on, when the pain hasn't really gotten very severe yet, that giving some carbohydrates in that specific setting during that period of time may be helpful in reducing the heme demand in the liver if part of what drove the heme demand was prolonged, starvation. The other thing that the other place where this can play a role is as patients have a couple of days of onset of symptoms, they may start developing more abdominal pain and nausea. They may not be able to take in any foods. And then they start developing a prolonged starvation state, which can exacerbate an ongoing acute attack. Again, in that setting, having some dextrose infusions, when you first go to the hospital for treatment of acute attack is perfectly safe and may be effective, again, in the early stages of an attack.
D5, D10,
D5, D5 doesn't really matter.
Okay.
It's just we need to get, it'd be helpful in that case both to get some some hydration in you, because patients are oftentimes dehydrated because they've been nauseous, maybe have been throwing up and haven't been able to drink much during the first couple of days of an attack. But I want to emphasize that dextrose infusions, carbohydrates in general, have never been shown to be able to prevent acute attacks, and they've really never been shown to be able to actually stop an acute attack. Okay, so can be helpful in the early stages, really mainly because it's safe. And so in most patients need a little bit of hydration anyways. And so just kind of the general practice has been that, if you have an attack and you're coming in, we're going to get you some dextrose infusions. And then also, I do think that, taking in some, drinking some fruit juice in the first, when you first start feeling some symptoms, that might have a little bit of effect in helping get rid of an attack. Okay,
so
but
it's kind of a rescue food.
Correct. Yeah, but it's not really going to be able to. It's not going to stop in the severe attack. Okay, so you still it shouldn't take the place of panhematin. Okay, so that's one. So two is it doesn't help prevent attacks. Okay, so I really advise against patients taking in carbohydrates or more so than their usual diet would indicate as a means of trying to prevent attacks. Okay, that has never been shown to be effective. But what it does do is it'll put you at risk of increased weight gain and other metabolic effects that are going to be detrimental to the body. So I would not recommend against carbohydrate loading and in general in patients with acute porphyrias. Protein, there's not a big connection here in terms of protein, either increase excess protein intake or lower protein intake in terms of heme production in the liver. My general advice for patients is with acute porphyria is just maintain a healthy diet, maintain an active lifestyle, and that's probably the best way for you to minimize risk of having induced attacks.
Okay, great. Thank you. That's really critical information. All of it's really critical information. So I'm going to ask about CEP. And this is a woman who her 6-year-old daughter has CEP, or congenital erythropoietic porphyria, and she now has mild splenomegaly. I hope I said that correctly.
Yes.
Can you speak to this? And I believe this patient is, it's far from we're not in the U.S. So in thinking through this, what should their physicians be looking at, or what steps should they be taking?
Yeah. So in CEP, the levels of porphyrins, again, it's produced in red blood cells, so very similar to EPP in that, in what the source of the production is. There are very high production of porphyrins, especially uroporphyrins, in patients with CEP, and the levels are so high that it can cause the red blood cells to break apart and die. Okay, and it is that process of really, breakdown of red blood cells that can cause the splenomegaly. It leads to a very enlarged spleen that can cause symptoms for patients, and that can cause further abnormalities in their blood tests. A really enlarged spleen can cause the platelets, for example, to break down, break down more. And so some of those patients may eventually need the removal of their spleen if the spleen enlargement is really causing a lot of symptoms. Now, underlying treatment for CEP. So obviously for, sunlight avoidance and protection is extremely important in patients with CEP. So unlike patients with PCT or VP and HCP who will have similar blistering skin lesions, with CEP, the levels of porphyrins are much higher. And they're so high, in fact, that it interferes with the wound healing process. So even though the initial blisters may look the same, once the blisters get unroofed, the healing of those opened wounds is much slower than even in PCT. It's already very slow in PCT, but it is even slower in CEP. And in fact, there's a very high chance of getting infections in these unhealed wounds. And that over time can lead to loss of soft tissue. That could be especially in the extremities of the body, the nose, ears, digits, distal parts of fingers, eyebrows, eyelids. All over. So sunlight avoidance is really key. If there is hemolytic anemia, so that's the breakdown of red blood cells, that may require transfusion. Okay. The only way to cure CEP would be with a bone marrow transplant, and that would be to replace the cells that make the red blood cells from, with stem cells from somebody who does not have the genetic mutation of CEP. There have been a number of bone marrow transplants that have been done on kids with CEP. Obviously, bone marrow transplant is a very serious procedure that carries with it significant health risks. But that's something that I think should be discussed if your child has anemia and needs blood transfusions as a result of the CEP. And oftentimes that's also the scenario where we see splenomegaly.
Okay, great. Thank you. We had talked about medications and triggering attacks in acute hepatic porphyria, but the question is specific to HCP. Do medicines cause HCP attacks?
Yes. All medications that induce heme production in the liver can trigger an acute attack, and this is true for AIP patients, for VP patients, for HCP patients, and then also the rare ADP, ALAD porphyria patients out there.
Okay, great. Is the COVID-19 shot safe to get with EPP? Can you tell I'm trying to get to all the questions in our last 2 minutes here? I said rapid fire.
Yes, it is. The COVID vaccine is safe for EPP patients, as it is for the acute porphyria patients.
Okay, and being that we're on vaccines, how about all vaccines safety? Can you speak just to it fully?
Yes, we have not seen any vaccine-induced acute porphyria attacks. We've also not seen any vaccine-induced EPP, worsening of EPP symptoms or other cutaneous porphyria symptoms.
Okay, and the same question applies for medication that can be taken after a COVID or during a COVID attack to alleviate that, to make COVID less severe. Is that safe in the porphyrias?
Yes, that is safe for porphyrias. It does not significantly induce heme production in the liver, so safe for acute porphyria patients to take.
Okay. Is neuropathy a thing in EPP? I have a patient who's experiencing itching and burning in their feet, not after sun exposure. Can neuropathy be related to EPP, or is this something else going on with this patient?
Yeah, this is something else that's happening. So for EPP, as well as the other cutaneous porphyrias, really we only get symptoms in sunlight exposed areas. So if you're having symptoms in the trunk, on the legs, parts of the body that are not exposed to sunlight, something else is going on, and you should have that looked into.
Okay, I'm going to do one more. You got time for it?
Yes.
Okay. My 15-year-old daughter has AIP diagnosed by a hematologist. and has experienced improvement with panhematin, although her biochemical markers have not been elevated to the levels consistent with her symptoms. Is this an issue? She's a teenager. Are there others where this is happening, or is this particular to this patient?
Yeah, I think,
it's a hard one for
yeah,
the last question.
yeah. So I want to emphasize that panhematin, the way that it works to stop an acute attack is by lowering levels of ALA and PBG. Okay. We didn't have time to get too much into side effects of these medications. Okay, but panhematin does have side effects. It requires infusion through a central vein. So every time you get it, you have to have a PICC line placed, or patients who need it long term, you have to have a surgical procedure to get a port placed. That carries with it risk of having very serious blood infections. Panhematin itself can cause really severe chemical burns to peripheral veins that can cause very serious blood clots, and then requires people to take blood thinners over a long period of time to prevent even more serious blood clots happening elsewhere in the body. It can have, pretty rare, but it can cause allergic reactions. And then, prolonged doses, repeated doses of panhematin will definitely give you iron overload, and that can cause a whole series of issues. Okay, so we really only want to give panhematin if there is really good evidence that the ALA and PBG are really elevated. Okay, patients can have symptoms that look a lot like acute porphyria attacks for other reasons. Okay, but really, I really depend on and rely on the biochemical data to tell me whether or not a patient's symptoms are due to acute porphyria attacks or not, and whether or not treatment with panhematin or long-term treatment with gavosiran will be helpful in that patient. Okay, in this case, I wonder if there's something else happening if the ALA and PBG is repeatedly normal. Okay, patients can get improvement when they get panhematin, but it doesn't necessarily mean that we're treating the right thing. And in this case, I'd worry that we may, in the long run, cause more harm than good if we end up missing what the true underlying cause of the symptoms are in this girl.
Okay. Whew. Are you ready for a drink of water now after all this? Dr. Wang, that is all we have time for today. We have just gone over an hour, but on behalf of the Porphyria patient community and United Porphyrias, I just want to thank you so much for your time, your expertise, dedication. You are an absolute superhero to us. So thank you very, very much. Just know how much you are appreciated.
You're very welcome.
For everybody, thank you. For everybody out there, if we did not get to your questions, and of course, whenever you have questions, please send them our way. These are special events, but this is not the only time we can do questions for Dr. Wang and his colleagues with the Porphyrias Consortium and the United Porphyrias Scientific Advisory Board. So never hesitate to come to us for support and with your questions. And this video, we are going to, once it is complete, the event is over, we will post it live on the Porphyria Together Facebook group so people can go back and watch it if there was a particular area that was interesting to you. So thank you for joining this special event for Global Porphyria Day. Global Porphyria Day is tomorrow, May 18th, and UPA has been and will continue to do special events. You can check out all our social media pages for the Real People, Real Pain events and challenges. And we hope you'll join us in sharing posts and sharing our links and making your own to make more public awareness about porphyrias and the impact it has on our community. So thank you so much. Everybody have a wonderful day. Get out your purple, your ribbons, your badges, everything you got. And thank you. Have a wonderful Saturday.